There's a lot of buzz around the meeting about biocompatibility. EuroPD News had the opportunity to discuss this with key investigators.
I'm here with Ty Shockley. Ty, can you tell us about the recently completed Impendia-Eden trial?
Yes, Jeremy, yes, sir. Impendia and Eden are part of an integrated clinical trial program designed to evaluate an important unanswered question in PD, namely, what is the impact of glucose-sparing PD prescriptions on metabolic control in diabetic PD patients? Now, trials have robust study design. They are prospective, multi-center RCTs. The primary endpoint is improved metabolic control as measured by a change in HbA1c from baseline to 6 months. Now, as you can imagine, we've got a number of secondary endpoints, including change in glycemic control medications, lipid parameters, nutritional status, and quality of life. Now, subjects were randomized 1-to-1 to either a treatment group that included PD prescriptions containing non-glucose PD solutions, extranil, which is icodextrin-based, and nutranil, which is amino acid-based, or to control, which was dianil, which is glucose only. Now, in total, we had 53 sites from 11 countries, so truly an international study. We had countries from Europe, from North America, from South America, and throughout Asia Pacific. Now, I want to take this opportunity to sincerely thank all of the investigators for all of their hard work in conducting the study. Now, the study program commenced patient enrollment in February 2008.
What's the status of the trial now?
Well, I'm very happy to report that in January of this year, we terminated enrollment. We had a total of 251 patients enrolled. This exceeded our target, which was 236. So the last patient, last visit is July of this year. So that means the team right now is busy locking down and cleaning up the database. And obviously after that, we'll analyze the data and hopefully have results in the early part of 2012. The plan is to present the results at the EDTA meeting in Paris next year.
Pete, could you explain what glucose-sparing regimens are?
Today, there are two regimens possible. It's either combining glucose-based solution with icodextrin or combining glucose-based solutions with icodextrin and amino acid-based solutions. That is basically the two options we have available now.
Could you explain the benefits of these two regimens?
First, of the combination of combining glucose and icodextrin, there is quite a bit of data demonstrating that there is better ultrafiltration, there is better effects on left ventricular hypertrophy, there seems to be better metabolic outcomes, and most importantly, just recently shown in Korea, that there seems to be a survival advantage. From the other combination, less data are available. So far, there is evidence that the clinical outcome is the same combined with routine regimens, but there are some conflicting laboratory results really questioning at the moment if they are at the present combination better than just standard solution or the combination of glucose-based solution and icodextrin.
Hello, David. Could you expand on the recent research that highlights the importance of biocompatibility in PD?
Thanks, Jeremy. Well, we've just finished a large multi-centre, multi-country randomised control trial of biocompatible fluids versus standard fluids. The trial involved 185 patients who were new to peritoneal dialysis, who were followed for over a 2-year period in those 16 centres. And the results we found are quite exciting. That we found that those patients who got treated with biocompatible fluids had a significantly better preservation of their residual kidney function, particularly in the first year of the treatment. They became anuric much later in the course of their peritoneal dialysis than those who had been treated with standard solutions. They had a 50% reduction in time to first peritonitis and a 36% reduction in peritonitis rates. Moreover, we found good evidence that their peritoneal membrane was better preserved in terms of there was better preservation of peritoneal ultrafiltration, even when we corrected for the amount of glucose that they were receiving, and there was better preservation of their peritoneal membrane transport status over time, which was stable, as opposed to the standard group that had a progressive rise towards a high transport status in those who received the standard solutions. So I guess in a thumbnail sketch, the trial clearly shows that biocompatible fluids provide clinically important and statistically significant benefits for peritoneal dialysis patients.
Where do you think these developments will take us in the future?
Well, I think the BALANCE trial really adds quite strong evidence that patient outcomes are significantly improved with biocompatible fluids, and I think that taken that in the context with the trials that have gone previously, I suspect that there will be a natural evolution towards moving towards biocompatible fluids as the standard of care for peritoneal dialysis patients.
Edwina Brown and Brendan McCormick discuss different aspects of APD and assisted PD in the elderly. Edwina, can you tell us the benefits of PD in the elderly?
The main benefit is that the patient takes control of their own dialysis and fits it into their existing lifestyle. So they manage to keep their treatment at home. They very rarely have to go to hospital. They're much more independent. They can travel. They can look after their grandchildren. They can follow their hobbies. And they avoid spending much of their time going to hemodialysis, having transport, and they avoid the swings of hemodialysis. Many older patients on HD collapse their blood pressure. They feel washed out and drained by hemodialysis, and describe that they don't feel better almost until they need their next dialysis. So their general well-being are often much better preserved.
What are the key results of the BOLD study?
We have shown that the quality of life of patients on PD compared to hemo, at least in terms of illness intrusion into their life, is much better on peritoneal dialysis. We've also looked at patient decision making and shown that many patients are actually not involved in making the decision about choice of dialysis modality, though the majority of them want to be involved. And we've also been looking at factors, how patients make the choice of dialysis, and shown that it's a combination of medical factors, doctors telling them what they should do, as well as social factors, and also patients using their own life experiences, trying to decide which type of dialysis modality is suitable for them. But also we've shown as to how important it is for them to make the correct decision after good education, because if they end up on the wrong type of dialysis for some reason, it makes it much more difficult for them to adapt to life-on dialysis treatment.
Dr. McCormick, you use case-based learning in your presentation. What do you like about this method of educating clinicians?
I think case-based learning is a great way to engage your audience and to hold their attention. Most of the audience are made up of clinicians, and this is something highly relevant to them, and it does hold their attention, especially by the time you get to the end of a long day at a conference where the attention span may be shortening. In addition, I think that case-based learning is excellent in the sense that it allows you to highlight the science behind a lot of your clinical decision-making, while at the same time allow you to sort of show how a lot of the decision-making is also somewhat of an art as well. And in peritoneal dialysis especially, it is very much an area where you emphasize both the art and the science of clinical medicine.
EuroPD News is joined by Peter Margetts, Donald Fraser and Manuel Lopez Cabrera to discuss the novel process in peritoneal fibrosis.
Thank you. So we had a session today. We were looking at the peritoneal cavity, which is where the peritoneal dialysis solution goes, lined by an epithelial-like cell type, and the cell type gets injured during peritoneal dialysis. it undergoes a cellular transition process, migrates into the tissue, and turns into a fibroblast, which causes all sorts of problems in the tissue, and eventually leads to fibrosis and angiogenesis. And Dr. Lopez Cabrera has done a lot of work looking at this in the humans, and he gave an excellent talk describing this, and we're looking at how this process occurs and how we can work towards reversing it.
So thank you. Yes. Well, the first evidence that we had about the EMT process in human was published by our group in 2003 in a landmark paper in New England Journal of Medicine. More than 8 years later, the EMT process, the hypothesis of the EMT process in the peritoneal fibrosis has grown more and more every year, and now we are discussing in a session like the one we had today is to know how this process takes place, to know deeply the molecular mechanism that is involved in the EMT process. With the whole idea is that probably in the near future we could find any targets that can block or reverse the EMT process to prevent peritoneal fibrosis.
So in the session we had a very nice laying out of all of the evidence for EMT in the peritoneal cavity by the two co-presenters, and my role was to talk briefly about a new player that might be important in EMT, something called microRNAs, what's called a post-transcriptional regulator, something that can switch off particular genes and stop them from being expressed. And there's some emerging evidence that this may be a key mechanism by which EMT is controlled. It would be fascinating to see whether that's the case in the mesothelial cell as it is elsewhere in the body.
Okay, great. Thank you very much for your time.
Thank you.
Thanks.
Thank you.